My name is Heather Gardner, and my project is over access to healthcare, how it affects emergency rooms, and utilizing patient navigators. I spoke to my mentor, Stephen Bennett, about access to healthcare, how it affects the emergency room, and utilizing patient navigators. My project setting is at Woodland Heights Medical Center in Lufkin, Texas. Patient navigation is designed to reduce healthcare disparities by assisting patients in overcoming barriers to high quality care for a health outcome. Emergency rooms are utilized by patients from all walks of life, but more by those that are unable to utilize healthcare services such as physician offices, healthcare insurance, or prescription medications. Patient navigators play an important role in connecting patients with resources from the community. They also refer patients to local physicians and help them set up appointments for long-term care. Patient navigators follow up with patients to make sure they went to their appointments, and if the patient did not go to their appointment, the patient navigator reschedules the appointment for the patient. Patient navigators are utilized to reduce an existing health disparity as defined in a particular community. Patient navigators address the individual barriers of each patient by coordinating the patient with pre-existing resources. Patient navigators work as a team with area physician office staff. Many patients come to the emergency department because they do not have access to healthcare insurance, do not have a primary care physician, or are unable to get in to see their PCP that day. Patient navigators can teach patients when to utilize the ED and when to utilize their PCP if they have one. If they do not have one and or do not have insurance, the patient navigator helps the patient find a PCP and make an appointment for them, as well as helping them find insurance. Overcrowding the ED has been linked to decreased quality of care, increased costs, and patient dissatisfaction. With our project, we want to implement a patient navigation program to address patients that overuse the emergency department. We want to hire, prepare, supervise, support, retain effective patient navigators. We also want to evaluate patient navigation programs for continuous quality improvement. When we address the stakeholders, we want to touch on presenting the proposal to the stakeholders and explain the need for patient navigators, touch on quality of health and patient satisfaction, and address providers' expectations. The Agency of Healthcare Research and Quality says that we should include our stakeholders through every stage for any program that we implement. Although this particular article is about Medicaid, we can use these suggestions for any program. Our stakeholders build support for it, provide suggestions for its design, and participate in evaluation and continuous quality improvement activities. It is important to find a program champion that will take the time to help with implementing a new program. This person will be an influential candidate and will share their expertise based on their experience, promote program continuation and sustainability, and help manage their other stakeholders' expectations. When addressing the stakeholder, it will be important to discuss the cost of the project, the outcomes to be expected, and the quality of patients' health that will be improved, provider expectations and satisfaction, and the quality of life that patients will receive, and how this project will help with patient satisfaction. By allowing stakeholders to be involved in every aspect of the designing and planning of this project, we can improve early buy-in on the project for key stakeholders, have a program that has a successful design, and will have long-term support. When addressing all stakeholders, such as those that support, aren't swayed either way, and those that resist it, it is important to remind them that we are to help those in need, and by providing a service such as a patient navigator, we are doing just that. We are connecting the underserved with resources they do not currently have. The Bible says, bear one another's burdens, and so fulfill the law of Christ. It is also important to remind those that resist that this is a service we are doing for our community, and that we will be remembered by those we help. Some stakeholders that might support this project could include board members, chief nursing officer, chief executive officer, area physicians, chief operating officer, director of emergency services, insurance companies, patients, social workers, and case managers. This project will be funded by grants provided by physicians in the community, so there shouldn't be too many stakeholders that resist this project. Other stakeholders include community churches, transportation agencies, local police agencies, social services, shelters for the homeless and victims of violence, healthcare centers, and voluntary organizations. There are stakeholders that won't be swayed either way. Those could include pharmacy directors, IT personnel, admissions director, policymakers, and human resources. The chief financial officer might resist the patient navigator role if the funds are from Woodland Heights Medical Center's budget, but this particular budget is provided through a grant from area physicians of approximately $200,000, so this might sway the CFO towards the PN role. The CFO has to be a good steward of all funds that come into the facility. ensuring that each fund disbursement is earmarked appropriately. Proverbs 22:7 says, "The rich rules over the poor, and the borrower is the slave of the lender." This means that the CFO is taking in extra funds and will be obligated to ensure they go to the appropriate department. Nurses, unit clerks, and technicians might resist this project because of days that there is low patient volume. These employees are sent home either way, either without pay or paid from their PTO account. If more patients are utilizing their PCP because of this program, it will decrease the amount of patients seen in the ED, forcing PTO usage. Some of our goals include reaching out to the underserved population and screening them for services, breaking barriers in the care patients should be receiving while also connecting these patients to resources, and alleviating unnecessary costs and resources used to see patients that could be seen by their primary care physician. According to the Boston Medical Center, the patient navigator is utilized as a barrier-focused intervention. In 2010, it was reported that 43.6 million Americans were poor, with 25% of those being African American and 25% of those being Hispanic American. The other 50% of the uninsured and poor population are Caucasian. In that same year, it was estimated that 50 million Americans did not have health insurance, with 32% of them being Hispanic, 21% African American, and 12% Caucasian. Poverty is associated with low educational level, substandard living conditions, inadequate support, unemployment, risk-promoting lifestyle, and diminished access to timely health care. Some of the barriers that a patient navigator might be able to eliminate are communication, medical system, and psychological barriers. By utilizing patient navigators, we hope to break the barrier to health disparities and get patients the proper health care they deserve. Some of the resources that we will need will include funding, office space and supplies, computer and telephone equipment, educational materials, and we will need to train and orient the staff. It is expected that navigators will pay for themselves by lowering the overall cost of care and improving patient outcomes. It is important for patient navigators to be educated in their role so they can work effectively. There are courses that our patient navigators can take through the Patient Navigator Training Collaboration, as well as through the Harold P. Freeman Patient Navigation Institute. There are already resources out there to help create and implement a patient navigator role. We just need to use them instead of starting from scratch. We will use a spreadsheet to monitor the patients that are seen, appointments are made for, and how many go their appointments and how many do not show up. We will be able to look at patient volume before and after implementing patient navigators and see if those numbers decrease. The patient navigators will also have their own spreadsheet of patients they have talked to and how many patients are actually following up with their PCP they had an appointment with. The way patients respond to patient navigators will tell us if this plan is working or not. Patients will be given a choice as to whether they want to participate in the program or not. We will conduct a final assessment just as we did with the baseline, except there will be more data to review. We will also be able to analyze the reasons patients were seen in the ED and compare them to the baseline study. This study cannot be done in just a few weeks, but I believe will need to be looked at over at least a year. By utilizing patient navigation team, a free clinic reduced the no-show rate by 17.7%, and patients that did receive a patient navigation call were more likely to attend their first appointment, which was 72%, opposed to those that did not receive a call at 43%. Inequitable differences between groups of individuals, such as healthcare coverage, quality of care, and access to care, contribute to healthcare disparities. This same article states that two of the most prevalent quality issues are overuse and underuse. According to Langwell and Moser, ethnic groups other than Caucasian patients are more likely to report that they do not visit the doctor's office, use the ER more than Caucasians, although the Asian group use the ER even less than the Caucasians, and those that have Medicare managed care were more likely to visit their doctors and use prescription medications. So in conclusion, I spoke to my mentor, Stephen Bennett, about different topics and narrowed down my topic selection to access to healthcare, how it affects the emergency room, and utilizing patient navigators. My project setting is at Woodland Heights Medical Center, Lufkin, Texas. By utilizing patient navigators, we can overcome healthcare disparities and get patients the healthcare they deserve, freeing up the emergency department and using resources for patients that are critical.